want to thank the PAP members who are participating in this live, and we will be recording this presentation as well to distribute out via our listserv onto our website for the broader public. And so the purpose for today is really an overview of the progress through year 2 of the initiative. So still through early days, but I know this was a request specifically from individual PAP members, was to have a more detailed dive. And we, the state, Peggy Chan and myself are here, and then we also have PCG here to present the results through year 2. And talk a little bit about what those results mean relative to the rest of the initiative. Obviously, we have a ways to go here, but in terms of performance, and we have entered that really important performance phase. But definitely, we think there's some important lessons out of what we've seen to date in terms of performance. And we certainly are using this data in our active engagement with the PPSs. So we have gone, I would emphasize, from a system where mostly we were looking at the process steps. We were looking mostly at how PPSs were organizing themselves, how it appeared they were doing relative to their governance and standing themselves up, and what their turnover was potentially in their staff. Trying to use that as sort of tea leaves to predict how the PPSs would perform. We've now sort of moved beyond that phase and really now are beginning to get actionable data that is going to really influence our oversight responsibilities and really focusing on how our PPS is actually performing. I do want to say before we get into the numbers too, is that year 2 of this initiative was still very early days for many PPSs. I think as we've talked about, of the 25, varying ones some had a little bit of a leg up, maybe from prior investments or relationships that had existed previous to the initiative. Others were created whole cloth just at the start of DSRIP. And not all of them got out of the blocks with the same sort of vim and vigor. And some also, frankly, had a headwind going into this initiative, and some had a wind at their backs. So a little bit of what you're seeing relative to the performance is that you're seeing a little bit of the environment in which they began, in which they were formed. We said all along that every PPS, every community had its strengths, it has weaknesses, and they had to work to overcome their weaknesses and build on their strengths. But I do want to emphasize that, and we aren't here at the department, we're trying not to overreact either positively or negatively to the results to date, just because for a lot of these PPSs, they weren't really as fully engaged. A lot of the infrastructure, the projects that they had deployed that really were particularly connected to these measures were not fully deployed at this time. So with that, go to the next slide. All right, so here's the contents. As I said, I'll talk a little bit about sort of the high-level performance, then I'm going to turn it over to PCG to go through some of the specifics. We also provided a level of detail at the end of this. We're probably not going to go through it, but I know there was a particular interest among PAP members of greater detail on P4P measures through year 2. So we did attach some bubble charts that hopefully are helpful. If folks have questions relative to those charts, we're happy to walk people through and make sure that folks can fully appreciate. We actually do use a couple of examples in the presentation itself, so we can definitely make sure that folks understand how to interpret those charts. Next slide. Next slide. Okay, so in terms of overall performance, we've talked about this before, but just I think it's worth reiterating. PPSs have earned almost 96% of available funds through DSRIP year 2, quarter 4. Gives you a flavor of the amount that they've earned, $2.5 billion so far. But obviously most of that performance has been earned through meeting the process requirements of the initiative. But I think any PPS will tell you that there was a lot of work was put into achieving that, but it is a different thing to go from being able to demonstrate you're implementing projects and that you're doing the basic requirements of the initiative to actually performing and showing improvements in the health of the population you serve. So while so far so good in terms of actually earning the monies, it is still, as I say, early overall days. The other thing I would say, too, is PPSs themselves are really beginning to figure out which of the performance metrics are the ones that really drive the most significant funds in this initiative, and really focusing in on a subset of measures that are of great importance. They're being strategic, which I think we should not be surprised by. It does mean they're going to miss measures because they're simply going to be focusing on those ones that really have the biggest sort of bang for the buck from a dollar standpoint. I don't necessarily see that as a bad thing, so I'll give examples. As a result of focusing on certain measures, the measures they're going to be focusing on are for populations such as those with significant behavioral health needs. The quality bonus program, the high performance pool, half the money in there is directly linked to success in measures specifically for the high needs behavioral health population. And special focus on that population, I think, is actually a very positive thing. That's where you're going to find your chronically homeless, the folks who really are challenged by the social determinants of health the most of any element of our population. So them spending extra time and focus on that, I think, is actually a good thing. It does mean, however, that there will be certain other areas that may not get as much attention. And I think we'll monitor it, but at the end of the day, it's up to PPSs to decide where they want to focus their resources, and they're tending to want to focus their resources on those subset of measures, as I said, that drive the largest sums of money. Next slide. All right, how has the PPS performed so far? Well, in terms of the two top measures that we've identified are the avoidable hospital use measures. Folks remember that the primary goal of DSRIP was a 25% reduction in avoidable hospital use. Well, in terms of the PPRs and PPVs, or the potentially preventable readmissions and the potentially preventable ER visits, we've seen a marked decline even through year 2, 14.9, basically 15% reduction in readmissions and a 12% reduction in ER. When you extend this out beyond, and we'll show you a chart in terms of beyond the current, if you sort of project through the initiative, you'll see, go back. You'll see that you'll see in those charts, and PCG will get there in a minute, but you'll see in those charts that the PPSs are projected to actually exceed the goals of a 25% reduction. So other ways to think about overall PPS performance is to look at the projects and the projects they committed to doing. And if you remember the speed and scale commitments, we let the PPSs in this initiative choose projects. They could choose between 10 or 11 projects to commit to, and then they also got to commit to and decide how fast they wanted to implement those projects and on what scale they wanted to implement those projects. And each project has a series of milestones that are reviewed by the independent assessor to determine whether or not those milestones have been completed, so that they can determine whether or not a project has been fully implemented. So far, PPS has successfully met all project requirements for 31 projects through DY2. Once again, it's still early days. We do have PPSs who have, in fact, not met requirements. We had one PPS who came out of the box very aggressively in terms of expectations for them implementing projects, and they've not been able to fulfill those. That meant that they lost money on the administrative side as a result. So yeah, not to say all the projects are in fact being completed, not all of them are, but generally speaking, the vast majority of PPSs took a somewhat more conservative route in terms of when they thought the projects would be fully implemented, and so far 95% of all DY2 project requirements have successfully been implemented. So, but still more work to be done. Some of the PPSs have project requirements that go all the way into the 5th year of the initiative. If folks will remember how aggressive they were impacted their valuation. The more aggressive they were, meaning in terms of speed and scale, the more money they got in the initiative. But it varied in terms of the approach that the PPSs took, but they are in essence now living with those decisions they made, 3-4 years ago. So next slide. So with that, I'll turn it over now to PCG to walk us through, and we got Joe Weber here to walk us through the DSRIP program refresher.
Thanks, Jason. So before we get into some of the further details around some of the highlights that Jason just walked through, we did want to take some time and just go back and highlight for folks some of the mechanics around the DSRIP program and how the funding is shifting and has shifted already, but then also when we're looking at a performance environment, how those dollars are earned, how we're determining whether or not PPSs have met the requirements to earn the AVs. So jumping in on slide 8 here, this is really just a very high-level timeline of how the funds shift over the course of the DSRIP program. So in year 1, which ran from April of 2015 through March of 2016, 80% of the funding was tied to those Domain 1 process measures. So the efforts around implementing your governance structure, doing your workforce assessments, and spending funds towards meeting some of your workforce requirements. The other 20% was tied to pay for reporting. So on a number of the quality measures, as long as the data was available and the PPSs were submitting the required information associated with those measures, they received the payments and the AVs associated with those reporting requirements. As we shifted into year 2, which ended back in March of 2017, we saw for the first time some of the dollars shifting into the pay for performance bucket. And so we likewise saw money shifting from Domain 1 into Domain 2, 3, and 4 from a reporting perspective, and then also on the performance side. The thing to keep in mind with year 2 is those performance dollars were just strictly for your Domain 3 projects. So a number of your projects specific to the behavioral health population, the cardiovascular projects, things of that nature. The larger system transformation projects that we see in Domain 2, those all remained pay for reporting within year 2. But then as we start to look forward, and we're currently in year 3 of the demonstration, those funds continue to shift further away from the reporting and more into the performance side. And you can see we take a pretty significant jump forward in terms of the percentage of funding tied to pay for performance. We go from 9% in year 2 to 43% in year 3. And again, that trend continues all the way out to year 5, where 82% of the DSRIP funds are tied to PPS meeting their performance outcomes. In terms of thinking about that from a measure perspective, just like the funds transition from P for R into P for P, so do the measures. And so again, in year 2, it was a small number, 26 measures in total in Domain 3, shifted from pay for reporting into pay for performance. In year 3, we see that expand to include all Domain 2 measures as well as some additional Domain 3 measures. And then finally in year 4, we see the last of the measures that are going to convert into P for P. We see that happen in year 4. And as we note here in Appendix B of this deck, we have provided the full list of measures that convert in years 3 and 4 as part of the program. In moving to the next slide, this starts to speak to a bit to what Jason said earlier around some PPSs having some wind at their back as we move towards performance this first year in year 2, and taking a look at the actual dates of service, so when the services were being provided and how that aligns with the actual performance results and how that feeds into when PPSs earn their funds. So when we paid out pay for performance and made determinations on whether or not PPSs met their performance goals for year 2, we were actually looking at services that were provided by the PPSs and their network partners from during the period of July of 2015 through June of 2016. So there is, quite a lag in terms of when the actual performance takes place and when those dollars actually start to feed into and when those results start to impact PPS performance. So, we see that trend continue, that next year we'll be using, as part of the second payment of year 3, we'll be using data for a performance period that ran from July of 2016 through this past June of 2017. So just wanted to highlight that there is that bit of a lag between when the actual services are provided, when the activities are being performed by the PPSs, and when we actually have the data to determine the actual performance and make payments to PPSs.
Right, and I think that's one of the challenges with these claims-based, encounter-based measures that are the most common source of type of measure that we have and was negotiated with CMS, was that they are lagged, and that's why it takes time for the claims to become complete. And it's always been a challenge for the PPSs from the get-go, was that they'd have payments that would be, based on performance from a longer period back. It's also why we've been emphasizing, actually now for over a year, that we're in the performance phase. It's not something that we've just started saying. We've been saying, I think, for actually a year and a half, because performance does matter. It has mattered. It's just now beginning to see the performance translate into payments.
And so the last point to make here too is, again, just from a process standpoint, PPS is really, through the first 2 years of the program, we're focused on building the infrastructure in year 1 to be able to support their DSRIP efforts, and then in year 2 really starting to focus in on implementing their projects and standing up the projects that are going to drive the performance going forward. So I think as, again, the PPSs start to shift their focus to the performance away from process, we also expect that we'll see more of that emphasis on the performance measures and not as much on the process. So then moving into slide 10, for the first time this year, we were tasked with determining whether or not PPSs met their annual performance goals for the P4P measures. And so one of the things that I think is important for folks to know is how that process actually plays out, what that calculation looks like by measure for PPSs. And so the PPSs earn their P4P dollars by meeting or exceeding annual improvement targets for the applicable P4P measures. And the measures that apply to a PPS are going to be specific to that PPS. They're going to be specific to the projects that they selected. And so a PPS that selects, say, Project 3GI is going to have measures specific to through that particular project versus a PPS that selects a different project. And so that's one thing to keep in mind as we start to look at the performance results, that it is tied to some of their project selections. We'll talk in a little bit about something that we commonly refer to as the multiplier effect, because that also impacts some of the performance earnings of the PPSs. So when we talk about the annual improvement target, or the AIT, that's the PPS's specific performance goal for each year, for each measure that they're being evaluated on. And so it's calculated as 10% improvement during that year-over-year improvement, and it's either from the baseline or, in this case, because we were in year 2, the year 1 results served as our baseline. So it's a comparison of the current year performance against the prior year performance. And so just walking through a quick example here for one measure, again, the calculation would follow the same process for all measures, but we wanted to walk through a little example to hopefully clarify how the AIT is determined for a particular PPS on a measure. So here we have, for the potentially preventable emergency department visits for the behavioral health population, a specific PPS in year 1 had a performance result of 116.76. the statewide performance goal for this particular measure, which that statewide performance goal is the same for every PPS, is 35.29. And so the gap to goal, so the difference between the baseline and the statewide performance goal for this PPS is 81.47. And so for determining the annual improvement target, we would take 10% of that gap to goal amount. So that becomes the 8.14. And we then set the annual improvement target by subtracting that 8.14 from the baseline performance or the MY1 result here. So we would take the 116.76 less the 8.14 to set the annual improvement target for this PPS on this measure at 108.62. So then how that translates and how we factor that into determining whether or not the PPS met their goal is something we walk through in the next slide. And so here we take that same potentially preventable ED visit measure and we show it for two different PPSs, one that has met its target, one that hasn't. And so again, we have PPSA here, their baseline, their MY1 result was the 116.76. The statewide performance goal was the 35.29, and their annual improvement target, which we had calculated and showed on the previous slide, was the 108.62. This PPS, they actually only reduced their results from the 116.76 to the 115.53. So they did not reach their annual improvement target of the 108.62, so they would not earn the achievement value for this. Conversely, PPSB, they started out at 122.97. Their annual improvement target was calculated at the 114.2, and they actually performed and were able to reduce their potentially preventable ED visits down to 95.4. And so that 95.4 met and exceeded the target of 114.2. So this PPS would have earned the AV and met their performance goal for this measure. So then moving into the next slide, and we talk about the multiplier effect, this measure is actually a good example of that, in that measures are set based on grouping of projects and subdomains within each of domain 2 and 3. And so in this slide, we show all the measures that converted to P4P during year 2. And as you can see at the top, there's actually 11 measures associated with Project 3AI, which is the integration of behavioral health and primary care, to 3A4. And so these are all behavioral health focused projects. These same 11 measures apply consistently to every one of Project 3AI through 3A4. And so if a PPS selects Project 3AI, which all 25 PPSs did, and then also select, say, Project 3A2, if they were PPSB from the previous slide that met their annual improvement target, they would have met that annual improvement target for both of their projects that have this measure in it. So they would get an AV for Project 3AI. They would also get an AV in the associated payments for Project 3A2. Conversely, for PPSA, if they missed on the PPV measure, they miss on all projects that measure applies to. And that becomes increasingly important as we look at domain 2 measures shifting into P4P, because measures like the overall potentially preventable readmissions and potentially preventable emergency department visits touch every domain 2 project with the exception of Project 2DI, which is the project for the uninsured and the low utilizers. So the multiplier effect is that much more significant within domain 2 as we look forward to that. So that's just something to keep in mind as we talk about the shift to performance over the next couple of years.
And I think the point here to emphasize too is this is a hard task. The PPSs have lots of performance measures that they're going to be looking at, and money's going to flow based on it. I think that's in the face of all these metrics, in the face of all this challenge, that's why PPSs are being strategic and really focusing on the ones that have the maximum dollar impact.
And the other thing to just highlight on this slide is if you look at the 11 measures within that top band for Projects 3AI to 3A4, you'll note that a number of them have an HP at the front of them. That notes that those measures are also eligible for the High Performance Fund. And so not only does a PPS's performance influence their regular performance fund earnings, but, excuse me, for a measure like the potentially preventable ED visit here for the 3AI project, that measure also allows them to earn funding from the high performance pool. And so we get into on the next slide just some mechanics around the high performance pool, but again, those particular measures are ones that carry significant value to the PPS because they are not only influencing their regular performance earnings, but also give them the opportunity to earn additional funds through the high performance based on their actual outcomes. So moving into slide 13 here, just in the high performance fund, there are a number of nuanced mechanics within it about how the dollars are actually distributed to PPSs once they've earned out of it. But in general, the high performance fund, it's a specific set aside that's called for in the STCs of the waiver. It's designed to reward those PPSs that perform at an exceedingly high level for a specific subset of measures. And there's actually two ways that a PPS can earn from the high performance fund. So the first way, which referred to as Tier 1, means that a PPS achieves a 20% improvement year over year, so from baseline towards the statewide performance goal in a measurement year. So as we look back at PPSB in our example on slide 11, they actually were a PPS that not only met their 10% annual improvement target, but they actually performed so well that they hit a 20% improvement from their prior year towards meeting that statewide performance goal. So by meeting or exceeding a 20% improvement in that year, that PPS would have been eligible to earn dollars out of the high performance fund. The second way, which is for even higher performance in Tier 2, is available to those PPSs that are able to meet the statewide performance goal in a particular measurement year. So if there had been a PPS that on this potentially preventable ED visit measure had been able to achieve or attain the level of 35.29, which is the statewide performance goal, they would be eligible to earn out of the Tier 2 high performance fund. And that's important because the STCs also state that any high performance fund dollars are split between Tier 1 and Tier 2. So for those PPSs that are able to achieve the higher bar associated with Tier 2, there is potentially a larger pot of money that's available there. The other thing to note about the high performance fund is that it is not necessarily an open-ended pot of money to PPSs, that the STCs require that no more than 30% of a PPS's total project valuation can be earned through the high performance fund. So there is a cap to how much PPSs can earn through the high performance fund, but it is a substantial amount of money that is available to PPSs that perform at a high level on those specific measures. So in addition to the regular performance and the high performance, there's also, as part of the $2.5 billion that PPSs have earned to date, there's also additional funds that were made available to PPSs, and they're referred to as the supplemental programs. And so the first one, the Equity Infrastructure Program, it's available to 15 of the PPSs. That program is much more focused on process and infrastructure building. It is more aligned with the Domain 1 process of being able to demonstrate that the PPSs met certain organizational requirements or infrastructure building requirements. The second bucket is the Equity Performance Program. Again, that's available to the same 15 PPSs, and that program aligns much more closely with the pay for performance side of the DSRIP program, that PPSs have to meet annual improvement targets in order to earn dollars there. There's a subset of measures that PPSs were able to select from. They had to select 6 EPP eligible measures. The other thing that's nuanced about the equity performance program is that PPSs can also earn funds based on partial achievement towards meeting their annual improvement target. So if a PPS only reaches 50% of their annual improvement target, they would be able to earn 50% of the associated payment. And so that is a little bit of a nuanced difference here for the equity performance side. The last part of the supplemental programs is the additional high performance program on slide 15. And that is available, that funding is available to each of the 25 PPSs. It's again designed to further incentivize high performance on those specific high performance eligible measures. PPSs can earn their additional high performance funding by meeting improvement targets for not at least 50% of the measures in the additional high performance pool. The one thing to note here is that the additional high performance pool is completely redistributive in the sense that there is a pot of $50 million available to all PPSs each year for additional high performance. There are no caps associated with it, and so all $50 million are distributed each year to the PPSs that earn it. And so there is the potential here for PPSs to earn a significant amount of money, and we actually saw in year 2 that play out for a number of PPSs to be able to earn a significant chunk of funding from the additional high performance program. So moving on, and what we're going to go through next is just some more detail about how the funding earnings broke out, a little bit more detail about how the PPSs earn their $2.5 billion to date. So if we go to slide 17, what this really shows is that our breakdown of the available versus the earned dollars broken into the various funding buckets. So at the top, the first 3 lines, that's related to the regular DSRIP funds. Our P4R dollars, again, made up a significant chunk of the available earnings for PPSs, and they continue to perform at an extremely high level. They earn 98.3% of those dollars. In pay for performance and high performance, there were no dollars available in year 2. Those did become available starting in they weren't available in year 1. They did become available in year 2, and I think this shows that PPSs did perform well, but there is opportunity for improvement on the performance side for the PPSs. The one thing to note on the high performance side is that because of the annual caps on PPS earnings, that PPSs and that we weren't able to distribute the full amount of dollars that were available, so we do have some unearned funding there. I think the 52.6% earned is a bit misleading in that the money that wasn't earned was due to restrictions on all of the Tier 1 funds were distributed, and there was only one PPS that made it into Tier 2, and they hit their 30% cap for the year. And so the money that's there wasn't due to lack of performance and PPS is not getting there. It was due to some of the constraints around how the high performance dollars are distributed. But the majority of the funding that was unearned is actually being carried forward into the year 3 high performance pool.
Right, and I think that's what the lesson learned for the PPSs are. The high performance pool does matter, and it's going to matter even more as time goes on, because we definitely do not anticipate that, for instance, the P4P for domains 2 and 3, we do not anticipate that will ever be 100%. Now, we do anticipate it going up above 52% as time goes on, primarily because the PPSs will be benefiting from all the investments, the infrastructure that didn't exist during DY2 that now exists in this much later phase. So I think that we're certainly hopeful that that will grow, but it will never be 100%, which means ultimately at the end of the day, what we'll see is dollars will fall out of that category and go into the high performance fund. And there's a limited set of measures for a part. I mean, those are those behavioral health measures, but then also it's the ability, if they can identify and really perform in a subset of things, they have an opportunity to gain. And was mentioned was that we did not distribute all the funds in that one area, and there was a relatively small PPS who happened to qualify for funds in that one area. I believe it was Rafua who qualified. So as a result, there's that 20% cap meant that funds were returned. So I think that one of the things that we've heard from the PPSs and them sort of better understanding this data is they now have a better understanding for the importance of that fund.
And then so just quickly down at the bottom, we have the 3 supplemental programs, and on the infrastructure and the additional high performance, 100% of the dollars available to date have been earned. And then on the performance program, almost all 97% of their dollars were earned there. So again, 95.8%, almost 96% of the available dollars to date have been earned by the PPSs. So then moving into slides 18 and 19, what we've done is provided a breakdown of the available funding that has been earned by PPS, as well as the achievement values earned by PPS. And so I think we're not going to spend much time going through individual PPSs. I think the message here is, again, to date, the PPSs have been performing at a very high level, that there's no PPS that is earned less than 90% of their available AVs or by extension their available funding. So again, the message is, as Jason started with, is that to date PPSs have demonstrated a high performance, but again, the looking forward is that the dynamic is shifting to focus on performance and less on the process.
Yeah, and I think that the result to some extent is somewhat predictable in the sense that they focus their energies on what drove most of the dollars at this phase, this early phase, and that was the process measures. They dedicate less resources on the outcomes, and now they're having to flip the switch. And I think what we're going to be monitoring on our end is how effectively they do that. And obviously we're here to support them in every way. We want them all to be successful. But where we see issues in the data that suggest performance is lagging, we're going to want to take the affirmative steps.
So then the last slide in this section is just a look ahead. And again, we've already moved into year 3. We're actually in the second quarter of year 3 at this point for the PPSs. But all we really want to do with this slide is just, again, show the shifting dynamic in terms of the funding moving from a reporting to a performance side. Within the top 2 lines there. And again, any unearned funds within the P for R and P for P bucket will shift into that high performance fund. So the $184 million that we're showing, that will continue to grow each year based on PPS performance for prior years. But there's still $4.7 billion of funding that's available to the PPSs over the last 3 years. So the next area we wanted to highlight is the progress on reducing the avoidable hospitalizations. And so one of the main goals of the DSRIP program is the 25% reduction over the 5-year demonstration. That emphasis right now is specifically on the PPR and the PPV measures. However, we are looking as well at how PPSs are trending on a larger set of measures that indicate their success at reducing hospitalization. So we are looking at the prevention quality or PQI indicator measures, the pediatric quality indicators, the PDI measures, and some of the potentially eventable complications or PAC measures to provide a more holistic look at how PPSs are impacting this particular measure of DSRIP success.
Because PAC is not a current measure.
PACs are not current measures, but they are a valuable component in looking at the VBP side of the world. And so there's, tying DSRIP into the overall move towards value-based, we also want to include PAC, which is a big component within the VBP world. So moving specifically into the PPRs and the PPVs, these were not pay-for-performance measures in year 2. They do become P for P measures in year 3, but we did want to take a look at these and take a look at how PPSs were progressing, where we were in terms of meeting that overall 25% reduction, and take a look at what current performance projects our results to be at the end of the 5 years. So moving into slide 23, looking first at the potentially preventable readmissions. And so what we're showing on the left-hand side of the chart is that in order to meet our goal at the end of the 5 years, from where we were at the start of DSRIP in year 0 to where we need to be at year 5, we're projecting a 5.6% average reduction across each year to meet that. Based on current performance, we're actually trending at a reduction of 7.7%. So we're actually trending ahead of where we need to be. Again, that's based on measures to date and performance to date. I think obviously this measure continues to increase in performance, but also continues to be a challenge. We'll continue to challenge PPSs in the coming years. So, but if we maintain current reduction rates, we would achieve a 33% reduction over the baseline over the life of the 5 years of the program. And so I think the next slide, 24, goes into some more of that detail around the PPSs, and as Jason mentioned, some of the bubble charts that we have in here. And so we have a number of these later in the deck, in particular in one of the appendices, but in just kind of looking at this, there's a lot of information, there's a lot of moving parts within this chart, but in terms of how to look at it, how to interpret it and understand it. So if we look at any single PPS, and you can see the PPSs along the left-hand side of the chart, and you can see the red line over to the left-hand side is our statewide performance goal for this PPR measure. What you can see is PPS performance on a year-by-year basis, and those are indicated by the different colored circles along their respective lines. So as we look at the top of the chart at the NYU Lutheran PPS, we can see that in year 0, they were at 382 potentially preventable readmissions per 100,000 Medicaid members. In year 1, they moved that down to 330 per 100,000 members, and then in year 2, they actually moved that to 153 PPRs per 100,000 members. So had this measure been performance driving in year 2, the PPS would have not only earned its P for P dollars, but it also would have reached into Tier 2 high performance by virtue of meeting that statewide performance goal. And so and you can see throughout the chart the same kind of color scheme and progress shown for each of the PPSs. I think the green diamonds are important in that they show that PPS result would have resulted in them meeting their annual improvement targets, would have resulted in them earning pay for performance dollars. I think what you can see down towards the bottom of the chart are some of those PPSs that they improved over their prior year results, but they did not improve enough to meet their annual improvement target. And then at the bottom of the chart, we actually see some PPSs below the dotted line under New York Presbyterian. You see some PPSs that are actually sliding back from their year 1 performance to year 2. And so that's just a high-level explanation of how to read this chart, how to interpret the information within it. And again, we have a couple more of these throughout the rest of the deck that we'll walk through.
Right, and I think it's good for folks to get comfortable with this, because this is what we're going to want to chart over time, is basically adding data points to this to show how each and every year the PPSs are performing in these key metrics. And obviously we want to see the march towards that red line and more PPSs. And now that said, as I said, take these data with a grain of salt, in the sense that some of these PPSs had, I said, the wind at their backs, others had the wind in their face, and that helped to, lead and impact results here. But I do think that, and in some cases, PPSs could perform really well at this phase, but now are going to have to maintain the performance. So you have 2 PPSs now that are already at the goal, but they, in essence, now have to find out a way to maintain that. But some of the other PPSs farther back, you know, they've got, I think in some cases it can be easier to make those incremental improvements if you've got, you start from a weaker base. And so just something that obviously we're going to be monitoring very closely.
So then moving into slide 25, we have the same type of setup related to the potentially preventable ED visits. Again, to move from where we were in year 0 to where our target is in year 5 to be able to meet the goal of the 25% reduction, it would require a 5.6% reduction. What we're actually seeing is that based on performance to date, we're forecasting that PPSs are on a trend for a 6.1% reduction, which would allow us to achieve a 26.9% reduction over the baseline. So again, meeting the goal of 25%. But as we said on the PPR measure, you know, current performance is not by any means an indicator of future performance, and that those PPSs that have performed well to date are going to have to find ways to keep it up going forward. And so slide 26 shows just again another look at the bubble chart that shows the PPS performance on this measure. And we have one of the PPSs that has moved this measure already to the statewide performance goal. And so the challenge to them is how do they maintain at that level? And there, you know, I think what we've seen here is that there were a larger number of PPSs that improved over their year 1 performance associated with this. We did have some backsliding, but in general, it was overall positive direction for the PPSs moving forward on this. Again, this wasn't a performance driving measure from a funding standpoint, and so the challenge is now all those PPSs with the green markers on their NY2 performance are going to be challenged to do that again in year 3, 4, and 5 when there's actual pay for performance dollars tied to this measure. And
just to be clear, that this is ranked from top to bottom in terms of biggest improvement, correct, over the 3-year period. So so as you're looking at the chart, if you're looking back and comparing it against the other, they're not sorted in the same and they're in alphabetical, whatever. It's based on the biggest improvement. So you saw that NYU Lutheran was at the top of the table for the PPRs, and here it's Central New York Care Collaborative at the top for the PPVs.
And the last thing that I forgot to mention when we went through the first one is the top line on both is actually an indicator of performance across all PPSs. So our statewide performance, and that's differentiated in that it uses a yellow or gold color scheme as opposed to the purple that's used for PPS performance. But as you look at the bubble charts, all PPS, the statewide performance will be always on the top of each chart.
Yeah, and if I could just one last thing before we skip to the next slide. A lot of focus at the midpoint assessment around both the assessment done by the independent assessor, really looking at how the PPSs were organized, how they were doing relative to their process measures, and that review. But I think that now we're going into a different phase and you need different sources of data. And I just mentioned Care Compass was a good example. That was a PPS that was flagged with more deficiencies than any other PPS, if I remember correctly. It's midpoint assessment by the IA, but here they are ranked 3rd in terms of improvements in one of the most important measures in DSRIP. So I think it's just an example. You know, a lot of factors go into the outcome measures, but you know, I think it's something where ultimately at the end of the day, this data and actual performance is what's really going to drive payments. It's going to be less about how we perceive them in terms of their organizational structure.
Okay. So the last section that we wanted to cover as part of the session this afternoon is around the statewide accountability measures. And so this is another component of the DSRIP program. It's a requirement in the STCs that govern it. And starting in year 3, so again, where we're at in the program, there's a set of 4 measures that the state is held accountable to for meeting in years 3, 4, and 5. And failure to meet these measures could result in a statewide penalty that would be applied across all PPSs. And so the 4 measures cover different components within the DSRIP program. The first one is just looking at a set of statewide performance metrics. So there's a subset of 18 measures that are flagged as part of the evaluation of the success of DSRIP for this particular performance measure. We'll actually get into that on the next slide in a little bit more detail. The second one is a success of the project statewide. This is a more all-encompassing look at the success of DSRIP across a larger universe of measures, both reporting and performance, and it's really focused on our PPSs earning more than what they are losing associated with those measures. The third of the 4 statewide measures is tied to total Medicaid spend, and it's inclusive of 2 components. The first part is the growth in the total Medicaid spend at or below a target trend rate. This particular component doesn't kick in until year 4, but the second component, the growth in statewide inpatient and ED spending at or below a defined target trend rate, that is applicable for years 3 through 5. And then the last of the 4 statewide accountability milestones is tied to the managed care plan, and that's really tied to the state meeting its VBP goals as they're outlined within the VBP roadmap. And so as I mentioned, failure to meet any of the 4, so if the PPS or if the state fails to meet just one of these 4 metrics, statewide penalties would be impacted. In year 3, it only accounts for about 5% of the total DSRIP funds, $74 million, but that penalty does increase over the last 3 years to $175 million, or 20% of funds in year 5. So looking at statewide accountability 1, on the next slide, what we found is in year 2, we had data that we could evaluate our statewide performance on for 16 of the 18 measures for which we're going to be held accountable. PPSs met 9 of those 16 measures, so we would have, based on the requirements, met our performance goal for statewide milestone 1. This wouldn't have resulted in statewide penalties being levied against us for this particular measure. We are, now that we're into year 3, more actively tracking this as well as measurement 2 in terms of PPS performance. We don't yet have, I think, a strong enough data set for year 3 to really project where we are on performance there, but it is something that we are looking at on an ongoing basis. The one thing, I think, because there are 7 of the 16 that showed that we worsened or we went backwards from year 1 to year 2, but I do think it's important to provide some context around those measures, that obviously we're not looking for our statewide performance to go backwards on any specific measure, but I do think there is important context to take into that. And so the next couple of slides, and we won't hit on all of them, but if we go to slide 31 here, or 31, which looks at primary care length of relationship, which was one of the 7 that worsened from year 1 to year 2. I think the thing that you'll notice is that overall statewide performance is very high on this measure, that these are measures tied to the CAP surveys, and that's an area where New York State traditionally has performed at a very high level. And so our statewide goal here is set at well over 90%, that most of the PPSs are performing in a very tight band around that statewide goal. And so the fact that we're worsening isn't necessarily a true indicator of performance, because there is so much that could influence even just a backslide of 1% based on how high the PPSs are performing and how high New York has historically performed on these measures.
And on this one, too, is we're engaging CMS around this because I think that at the time these measures were negotiated, we didn't really know what the performance level would be by PPS. And now we actually have CAHPS data that's done on a PPS by PPS level, which didn't exist prior when we were negotiating this. So we are looking at this and having to see if we can have a conversation about a slight tweak in how we actually score this particular measure.
And so the last couple of slides we have are just all, again, examples of some of those measures where we did show a worsening from year 1 to year 2. But I think the theme is consistent throughout that PPSs are generally performing at a very high level, that the backslide isn't really a big backslide, that we're still performing well within the statewide performance goal. So want to close just briefly with a couple of key takeaways. I think important points that we took away from looking at PPS performance today. I think first and foremost, as Jason mentioned at the start, PPSs have accomplished a great deal through the first 2 years of DSRIP. The 95.8% of funds earned, the 97% of available AVs that were earned indicate that, again, PPSs have by and large been meeting the expectations that were outlined for them through the first 2 years. The second point is there remains work to do over the last 3 years. Again, is the funding shifts from reporting and process measures into performance. We did see that in year 2, much of the losses in funding were tied to those performance areas. And so, of the 4 buckets that are tied to actual performance, 84% of those funds were earned. So below our 95% overall average. And so I think that points to an area where PPSs are continuing to turn their attention, but areas that we do want to pay attention to as a group going forward. And then the last thing is, again, years 3 through 5, the funding shifts significantly away from process and towards performance. That we had 9% of total funds in year 1 tied to, or in year 2 tied to performance, and that goes all the way up to 82% by the end of the DSRIP program. So a lot more attention on performance and something that is important to us and been made very clear to PPSs that I think they are turning their attention to. So that's the end of the slides that we plan to cover. We do have 2 appendices at the end of the deck that will be posted in conjunction with this webinar that provide some more bubble charts for some of the P4P measures from year 2. And then Appendix B just provides a more detailed listing or a further listing of the measures that convert during year 3 and year 4. So with that, I'll turn it back to Jason for closing remarks. And
thanks, Joe. And so, a lot of information. I think one of the challenges in DSRIP is there's just tremendous amounts of information. And anybody who's gone through the quarterly reports from the 25 PPSs sees just the magnitude of information. So we tried to summarize it as best we could, and obviously spend some time on a subset of the measures and walking through, particularly we want to make sure we walk through the bubble charts to make sure people understood how to interpret those. I think once you get comfortable with them, I think they'd be helpful. And then in the appendix, you have the full listing there, which, as I said, I think is helpful in terms of getting a sense. The only thing I would add to what Joe said was that, just emphasize, take the results today with a grain of salt, both on the positive and on the less positive side. This was still very early days from a performance standpoint. But I do think what you do see in the performance, particularly on some of the key metrics, is you see variation across our state in terms of performance in these measures. It's not surprising to me that we see that kind of variation. Generally speaking, in healthcare, when you look at cost and quality, you see significant variation, and that's exactly what we're seeing in DSRIP. But with variation comes opportunity. The opportunity to, in the areas where it's negative variation, meaning you have bad outcomes at higher costs, you have the opportunities to lower costs and improve outcomes. In the case of DSRIP, where we have poorer outcomes, it's opportunities for advancement, and DSRIP was built to reward PPSs, to reward providers as they get incrementally better and move towards the statewide goals. So you know, we are certainly looking at this and taking this data seriously, but as I said, we are taking it with a bit of a grain of salt. So with that, I think we're going to close this version of the presentation. This is the public version. So look forward to further dialogue with the public and broader stakeholders on this. There'll be more presentations in the future as more data becomes available. If you have any questions, please feel free to contact us through the normal route. When we send this out to the email listserv, we'll make sure we have the email contact. So if you do have questions, we're happy to answer those. But with that said, so we'll end this phase and then we'll open up questions to our payout members.